The Joker.
Pretty obvious, but if you want to do some kind of imaging, you can get an ultrasound, and classically an ultrasound, you'll see like a donut shape. Occasionally they call it the target sign. Okay, so if you see an exam question, donut shape on ultrasound or target sign, think of intussusception. Another thing you would actually use for diagnosis, which is also therapeutic, is an air enema, right? So you basically like use a hydraulic force to sort of reduce the intussusception, and it probably reduces the intussusception in like 75% of cases. If that doesn't work, obviously you go to surgery. And just as a quick addendum, what should you think about if this kid, after an air enema, becomes like septic, has like constant severe abdominal pain? I really hope you're thinking of an abdominal perforation, right? Because again, if you're blowing gas into a hollow viscus, imagine you could potentially perforate that viscus and can get into a lot of trouble, right? In general, for that, you probably want to do like an abdominal x-ray. You see free air under the diaphragm, right? That's like the classic thing you see. And basically for that, you need to give that kid broad spectrum antibiotics and just ship them to the OR because he has a pretty high mortality rate. Okay, so next question. So 4-year-old presents with severe generalized abdominal pain, nausea, and vomiting that started 12 hours ago. CBC is notable for a white count of 13,000, which is high. Ultrasound reveals an echogenic material in the right lower quadrant with what appears to be fat stranding. So right lower quadrant, fat stranding. So what's your diagnosis? How is this treated? And what are the potential complications? Okay, so this is I kind of wrote this question to sort of throw you off a little, but this is actually appendicitis. We're used to the periumbilical pain radiating to 2/3 the distance between the umbilicus and the anterior superior iliac spine, right? That's the classic appendicitis presentation in adults. But actually in the pediatric population, appendicitis tends to present as just generalized abdominal pain, okay? Just something to watch out for. That's why I added some extra for you with regards to the ultrasound findings, okay? And that sort of leads into the point that in general, the imaging test of choice for appendicitis in the pediatric population is an ultrasound, because you want to shield the kids from the radiation that accompanies a CT scan, which is classically done in adults. Okay. Basically, the echogenic material that we saw on ultrasound in this question, right? In general, for that, you probably want to do like an abdominal X-ray. You see free air under the diaphragm, right? That's like the classic thing you see. And basically for that, you need to give that kid broad spectrum antibiotics and just ship them to the OR because he has a pretty high mortality rate. Okay, so next question. So 4-year-old presents with severe generalized abdominal pain, nausea, and vomiting that started 12 hours ago. CBC is notable for a white count of 13,000, which is high. Ultrasound reveals an echogenic material in the right lower quadrant with what appears to be fat stranding. So right lower quadrant, fat stranding. So what's your diagnosis? How is this treated? And what are the potential complications? Okay, so this is I kind of wrote this question to sort of throw you off a little, but this is actually appendicitis. We're used to the periumbilical pain radiating to 2/3 the distance between the umbilicus and the anterior superior iliac spine, right? That's the classic appendicitis presentation in adults. But actually in the pediatric population, appendicitis tends to present as just generalized abdominal pain, okay? So just something to watch out for. That's why I added some extra for you with regards to the ultrasound findings, okay? And that sort of leads into the point that in general, the imaging test of choice for appendicitis in the pediatric population is an ultrasound, because you want to shield the kids from the radiation that accompanies the CT scan, which is classically done in adults. Okay. Basically, the echogenic material that we saw on ultrasound in this question was probably like fecalin that obstructed the appendix, caused inflammation, and then the kid had this problem. And in general, the way you treat this is you just hydrate the kid, give them broad spectrum antibiotics that covers your GI flora, like ciprofloxacin, which is a fluoroquinolone and metronidazole, or a combination of ampicillin, gentamicin, and remember gentamicin is an aminoglycoside and metronidazole. Okay, and then you send them to the OR for lab chole, right, laparoscopic cholecystectomy. And certain complications that could arise, especially in the pediatric population, is you could form an abscess, okay, or the appendix could actually perforate, and those are obviously worse conditions than garden variety appendicitis. And yeah, so I think I talked about all I want to talk about with this question. So let's jump to the next one. Okay, now the classically tested genetic principle. Okay, this question is extremely high interest of one. So basically, I'm just supplying the names of certain disorders, and then you tell me the genetic principle that's classically tested on exams. Okay, so the first group, we have a myotonic dystrophy and Fragile X syndrome. Myotonic dystrophy and Fragile X syndrome. Hopefully you know these to be trinucleotide repeat disorders. Okay, and I will talk about some of them in this podcast and in a later podcast. But remember that in Fragile X syndrome, you have the CGG repeats. It's an X-linked disorder. And for myotonic dystrophy, you have the CTG repeats. Okay. Now, next group, Engelmann syndrome, Prader-Willi syndrome, and Beckwith-Wiedemann syndrome. Okay. The key concepts later, but as a preview of coming attractions, remember that genomic imprinting just means that one of your chromosomes, either from mom or dad, is silenced. Okay? We'll talk about the pathophysiology behind Prader-Willi and Engelmann in a later slide. But for uniparental dysfunction, like both maternal chromosome 15s or both paternal chromosome 15s, instead of inheriting a paternal chromosome 15 and a maternal chromosome 15. We'll talk about the implication. So this classically arises from one of two things on exams, right? So it could be a translocation. Usually it's an unbalanced Robertsonian translocation. I'll talk about that later. It could also arise from maternal non-disjunction, okay? Maternal non-disjunction. Remember, maternal non-disjunction occurs when the homologous chromosomes do not separate in meiosis 1, or where the sister chromatids do not separate in meiosis 2, or where the sister chromatids do not separate in mitosis, okay? Those are all pathophysiological mechanisms behind maternal non-disjunction, and that can present with Down syndrome, okay? I'll talk about Down syndrome shortly. Now, next part says mom passing the disease to all her kids. So mom passing a disease to all her kids. Hopefully you're thinking of some MERF, like MERRF. There's one called Lee syndrome, LEIGH. But I would just say that one big thing, in fact there's another one actually that shows up on exams every now and then. It's like LHON, like Leber, hereditary. That can pass it on to his kids because all the mitochondria you have in your cells problems, that's one. Usually it's like some kind of optic atrophy. And then another thing is they may describe muscle biopsy that shows ragged red fibers. If you see that buzzword, you really want to think about some kind of mitochondrial disorder. Now, the final thing here is just a quick aside on the VACTERL association. It's just something you need to memorize. It's just a cluster of findings that tend to show up together in a kid, at least most or all of them. And the V stands for vertebral anomalies, okay? The A stands for anal atresia. The C stands for cardiac defects, many different kinds of cardiac defects. The TE stands for TE fistula, right? Usually that shows up with an esophageal atresia. The R stands for renal defect, okay? And then the L stands for limb defect, okay? So that's the VACTERL association. Vertebral anomalies, anal atresia, cardiac defects, TE fistula, classically with an esophageal atresia, renal problems, and limb defects, okay? Now let's jump on to the next question. Okay, so Down syndrome, okay? So I'm going to talk about the genetic pathophysiology. I'll talk about the early onset neurological disorder they can have, the classic hematologic malignancy that shows up in Downs. We'll talk about some concentrations before you begin sports. If a person has Down syndrome, we talk about the hand findings, we talk about the cardiac defects, we talk about the GI from the amniotic fluid, we'll talk about the chromosomes found in a Robertsonian translocation carrier. Classically, those people don't have Down syndrome, and then we'll talk about the number of things. It arises through two mechanisms you probably want to worry about for exams. Okay, it could arise from maternal non-disjunction. I've talked about the different combinations for that, right? So where you somatids in meiosis 2 or mitosis. Okay, and then another mechanism is the Robertsonian translocation. I'll talk about that in a bit. Okay, now the classic beta protein that classically accumulates in the brain in patients with Alzheimer's. Okay. Now, with regards to a hematologic malignancy, these kids tend to get ALL. Okay, remember, ALL classically on exams shows up in kids that are level Down syndrome. Okay, so that's one easy way to remember that. Now, before kids with Down syndrome start sports, one thing you actually want to do is to get like a cervical/neck X-ray. Okay, because the thing is, many kids with Down syndrome have something to like manipulate their neck and all that stuff. You want to get like some kind of cervical neck X-ray, okay, to rule out atlantoaxial subluxation. Okay. Now, the classic hand finding in Hirschsprung, right? So like the single palmar crease, some visual findings. I guess I didn't put this on the slide, but some visual findings. They may have like the palpebral fissures, the epicanthal folds, the low set ears, the small head, right? So those just sort of things to keep in mind there. Okay. With regards to cardiac problems, they tend to have endocardial Cushing defects, right? So like AV canal, your atrioventricular canal defects. Okay, because remember that those endocardial Cushings are derived from neural crest. And really, if you dug deeper and you spend time studying Down syndrome, you'll see that most of the problems in Downs are just from neural crest cell migration deficits. Okay, so that's what explains the disparate findings, like the problems they have with endocardial Cushing's, the problems they have with Hirschsprung's disease. These are all neural crest cell migration problems. Okay, with regards to GI problems, right? So they could have Hirschsprung. We talked about that. They could have duodenal atresia, right? So if you see an abdominal X-ray on your step 1 exam where you see a double bubble sign, okay, the first part of the bubble is the stomach up until the pyloric sphincter, and then the second part of the bubble is the part of the duodenum that's proximal to the atretic duodenal segment. Okay, that's your double bubble. You see that, think of Down syndrome, think of duodenal atresia. And duodenal atresia, right, classically presents with bilious vomiting. Contrast that with pyloric stenosis, where you think that they have, because remember, everyone has normal 2 copies of chromosome 21. So let's assume in the gamete, right, like the sperm of the egg, we pass on the chromosome 14 that is tethered to the long arm of chromosome 21, and then they also pass on a regular chromosome 21. When that gamete meets with another gamete that has like one single chromosome 21 gamete, the normal gamete, they have one copy from the abnormal gamete, and then they have the third copy that is tethered to chromosome 14. Okay, so they have performed a quad screen on maternal amniotic fluid. On amniotic fluid. In Down syndrome, you will have high levels of beta HCG and inhibin. Okay, and then you have low alpha fetoprotein and estriol. Okay, these are very easy. So let's jump on to the next question. Now, a 5-year-old male with a long face, large ears, and large testicles. So with this, what's your diagnosis? What's the mechanism of inheritance? What's the genetic pathophysiology and the associated principle? What's the diagnostic testing? So how do you diagnose this? What's the common psych association? What's the common neuro association? Believe it or not, these are all concepts they love to test on the exam. So if you see a kid with big everything, right? So like long face, big ears, big testicles, hopefully you're thinking about Fragile X syndrome. Okay, it's an X-linked disorder, right? So that's another reason it's higher, because most of the trinucleotide repeat disorders tend to be a principle of genetic anticipation. Okay. So this question describes a female with a low posterior hairline, congenital lymphedema, okay, and short stature. Okay, so what's your diagnosis? I really hope you're telling me that this patient has Turner syndrome, okay, and the karyotype, right, obviously is 45X, okay, it's 45X. Patients may actually have less severe symptoms. They have like in their 50s, for example. Okay, but hopefully you won't be one of them because you listened to this podcast and actually paid attention. Okay, so the close cousin is Noonan syndrome, and Noonan syndrome actually has many commonalities with Turner's, right? So you have like the cystic hygroma, you have the web neck, you have many of the same findings as Turner syndrome. Okay, but there are some key differences you want to recognize. Okay, boys, on your exam, you want to think really hard about Noonan syndrome. Although Noonan syndrome also shows up in girls because it actually has autosomal dominant inheritance. Okay, so it shows up in both boys and girls, but on exams, classically, it will show up in a boy. Okay, that's one. Another thing is the gene mutation is the PTPN1 gene mutation. That's very low yield. I don't really help you differentiate this Noonan from Turner syndrome on the exam. Is that in Turner syndrome, the kids tend to have a left ventricular outflow tract problem, right? So like coarctation of the aorta, bicuspid aortic valve. But in Noonan syndrome, the kids tend to have more of a right ventricular outflow tract problem, right? So LVOT problems in Turner syndrome, RVOT problems in Noonan syndrome, okay? Like pulmonic stenosis, for example, okay? So think more of left-sided heart problems with Turner's, right-sided heart problems with Noonan's, okay? At the absence of a tiny shadow on a newborn chest X-ray. And then the C stands for okay? So these kids could actually, very classic exam question is a kid presenting with hypocalcemic seizures, okay, and a prolonged QT interval, and a newborn EKG. Okay, think about the hypocalcemia and the hypoparathyroidism that accompanies the George syndrome, okay? And then the 22 stands for the deletion, the 22 to 11 deletion, the deletion of chromosome 22. Another syndrome that's lower yield but may show up on your exam, okay, that also has many of those catch-22 features is something known as velocardiofacial syndrome, okay? Velocardiofacial syndrome, okay? So, Prader-Willi versus Angelman, okay? So, the thing is, chromosome 15, in general, for this syndrome arises, shall we? Okay? So, there's two ways a person can get Prader-Willi syndrome. Again, I said, if you're a guy, you genetically imprint mom's chromosomes and express that chromosome. But let's assume you have a deletion of that chromosome 15, okay? Then you can certainly have Prader-Willi syndrome. Alternatively, if you inherit both chromosome 15s from mom, right? That's the principle known as uniparental disomy, right? So uniparental, one parent, disomy, two chromosomes, okay? That means that you shut off both of mom's chromosomes, you have no Dutch chromosomes to express in the first place, and have some problem where you syndrome, okay, very classic